is the first of the ESMRMB lab lectures exchange. So we're running this from our own labs, or actually from my living room. My name is Marion Smits, and I lead the Neuro-Oncology Imaging Group in Rotterdam, Erasmus MC. And we thought at ESMRMB, and I myself, that we should never waste a good crisis. So the fact that we're all doing this online lectures and doing our lab meetings online would be a great opportunity to, on the one hand, invite people outside our labs to give presentations and to have, you know, eminent guest speakers. And on the other hand, share this with a much wider group of people that outside our labs. So anybody who's an ESMRMB member can do this. So let us know at ESMRMB if you want to do this lab lecture exchange as well. So if you have a good speaker, or if you have something that you'd really like to share with, you know, the rest of the world, the ESMRMB world, then let us know and we'll set something up like this. So that's the introduction to the lab lectures, and I'm really, really pleased that we have a guest speaker from, well overseas, from California, Audrey Fan. So we've never actually, I think, met, but Esther Barnett in my group, she knows Audrey very well, and she said, well, we should have her as a speaker because she basically does very similar work to what we do, looking at the brain vascularization, combination of PET and MRI, and a little bit outside our field of oncology, but we're going to listen to stroke and dementia today. So Audrey, it's really great to have you here. It's great to meet you like this, and I'm really looking forward to your talk. Just a little sort of a practical announcement is that I have a window with the attendees. You're all muted. So if there is anything where you can't hear me or something, or can't hear Audrey, or can't see the screen, just type a question in the question box, and I'll be able to see that. And we'll also have some time for questions after. So please type the questions and I will read them out later, so that we can have a Q&A at the end. Well, with that, I'd like to give the floor to Audrey, and thanks again for being part of our first lab lecture exchange program.
No pressure. Thank you, Marion, for the introduction, and to Esther as well for the invite. I'm really excited to be here to talk about our PET MRI experience in stroke and dementia. Just as a little bit of background, I have an engineering training, and during my graduate school, I really focused on MR techniques, including acquisition and reconstruction. And it wasn't until I did my postdoc at Stanford with Greg Zaharchuk that I think I really gained experience with PET MR and learned how, since Greg is a neuroradiologist, how this can tie in directly to clinical use to help patients. And as of January, I have started an assistant professor position in biomedical engineering and neurology at the University of California, Davis, just in time for everything to shut down. So most of the work that you will be seeing today is actually from my time at Stanford with my colleagues there. But if you have any questions about what we're doing now, it's, you know, all fair game in terms of questions. So I'm really excited to be sharing this work. And in Davis, I am in the Department of Neurology, and in that department, I have the role of co-director of our neuroimaging core in the Alzheimer's Disease Research Center. So across the country, the National Institutes of Aging funds these research entities at different institutions that include imaging, but also neuropathology, clinical assessment of dementia. So I'm really now going from my stroke experience with Greg Zaharchuk at Stanford more into dementia. And my lab is actually in the city of Davis, really close to a Siemens 3 Tesla Skyra that we will be using to scan when things are safe again to scan. Now, let's get to the fun stuff, is the science. And really what I have been very interested in throughout my research experience so far is understanding how the brain meets its very high metabolic needs. There's no way to store oxygen in brain tissues, and so the brain relies on this constant delivery of cerebral blood flow and the subsequent extraction of oxygen to maintain the tissue health and viability. And this has really great impacts in terms of how we think about patients who suffer from cerebrovascular disease or acute stroke. And I would say for the past couple of decades at least, the standard of care for acute stroke patients has been relatively crude. And what I mean by that is it's very dependent on a single time threshold where in the past decades, if you're a stroke patient and you arrive to the hospital within 4.5 hours of symptom onset of your stroke, then you are eligible for a clotbuster drug called TPA. But if you arrive outside of that window, or perhaps you have a wake-up stroke, so you wake up in the middle of the night and you don't know when your symptoms may have started, then due to the risk of potential hemorrhage beyond that time window, you're not eligible for this clotbuster drug. But what that means is there's a lot of patients who potentially could benefit who are not receiving this treatment. And there's a long-standing understanding in stroke that although there's an area of infarct, the necrotic core affected by the stroke, in some patients there's an area of tissues adjacent to the core infarct called the penumbra. And this is tissue that has been affected adversely by the stroke, but is still potentially savable. And so the question is, these patients seem like they would be really great candidates to continue receiving treatment even beyond this time window. And exactly the biomarkers that we were talking about, including CDF and OEF, could give us some perspective into this penumbra. So for instance, a penumbra could be characterized by a reduction in flow due to the stroke, but a concomitant increase in oxygen extraction because the tissue is trying to compensate for that reduced flow. So if we can non-invasively image this, then that is a potential to identify patients to receive this treatment. And this sort of thought process exactly drove a recent study that was presented at the International Stroke Conference led by Stanford. And in the study, using CT or MR, as shown here, we had a imaging biomarker to potentially identify this penumbra. So in terms of diffusion, this represents the ischemic core, so tissue that is destined to die, and it shows a mismatch with the hypoperfusion, relative hypoperfusion assessed with contrast MR. And so if there's a large area affected, but a relatively small core, this mismatch indicates potential penumbra, relatively or qualitatively speaking. And when the investigators of the DIFFUSE-3 trial enrolled these patients, stratified by imaging, then these patients showed benefits with TPA as well as more advanced thrombectomy procedures well beyond the 4.5 hours. So this is just an example of how imaging right now is specifically looking at physiology and using that to guide our medical management and extending the window in which we can serve patients. So I find this a really exciting period to be working on brain physiology imaging. And I think we can do even better than this. And what I really work toward, and I think a lot of the members in Marian's group and Esther's group are also working toward, are using imaging to create these quantitative biomarkers of brain physiology. And throughout a lot of the history of imaging, this has fallen in the purview of PET, in the sense that we have understanding of the metabolic models that govern tracer uptake. There's an understanding that PET is quantitative, but this is really challenging because of need for radiation, and especially for brain physiology. A lot of the tracers that we're using are labeled with O15, and so these O15 tracers have a half-life of only 2 minutes, which makes it difficult to achieve in clinical settings. And how can we complement this with novel techniques that leverage the non-ionizing aspect of radiation from MRI, and potentially leverage the flexibility, quantitative methods, and spatial resolution improvements that MRI can offer. And so I really want to think about these modalities together. And my mission is to leverage to the best of our ability the synthesis of these technologies, these two modalities, to quantitatively image brain physiology. And so the rest of my talk, I will go through two topics. And the first is more cerebrovascular in nature. So I'm going to be talking about patients who are at high risk of stroke. And secondly, more moving toward understanding of dementia and neurodegeneration. And both of these will focus on PET-MR as a hybrid modality. So let's dive in. Let's start with the cerebrovascular story. And in this case, the particular population that we studied at Stanford is Moyamoya disease. And these patients tend to be quite young. They develop progressive stenosis or occlusion of arteries at the base of the brain and have increased risk of stroke. We don't fully understand why, since this is an idiopathic mechanism, but in these patients, there is the potential for brain physiology to identify who could benefit from extracranial to intracranial bypass surgeries, which our neurosurgeon collaborator performed on many of our cohort. In these patients, due to the obstruction at the base of the brain, many of the patients develop these collateral patterns, as shown here, to try to compensate. These are twisty, abnormal vessels that you can also see on a catheter-based angiogram. And when you compare this Moyamoya to a healthy case here, the collateral vessels appear very cloudy, and in Japanese, the Moyamoya term means puff of smoke. So I think this visually illustrates why we have this characterization of the disease as Moyamoya. And one of the things that makes the disease, from a technical standpoint, really a good test bed to develop methods is that these patients suffer some of the longest arterial transit delays that we see among cerebrovascular patients. And so, not only are they young, they're relatively compliant, but they have some of the most challenging collateral pathways with long transit. So if we can get some of our methods with arterial spin labeling to work in these patients, then we have accomplished this in some of the most challenging cases that we will see. So I mentioned ASL, and a lot of you will be familiar with this, but very briefly, it does not require a tracer injection. It uses radiofrequency labeling, typically at the level of the neck, in an MR magnet to non-invasively label blood spins that eventually flow into the imaging slab, as shown here in the brain. And the user defines this post-label delay to wait between the RF labeling and the imaging. And in a control setting, you don't apply this tag. And the difference between these two will be driven by a signal due purely to flow and perfusion. And so the maps that you get out of pseudo-continuous ASL look like a cerebral blood flow or perfusion map, where you're taking an average of the microvascular perfusion shown here. But you can already start to imagine that while this works nicely in healthy controls, it could be very challenging in patients with collateral patterns that are twisty and abnormal, and we don't actually know what the appropriate post-label delay from the imaging standpoint it should be. So this is the problem that we are trying to address in optimizing the ASL sequence. And I had the great opportunity at starting my postdoc at Stanford. It was also when the GE Cigna PET MR came out as a product and was installed at Stanford. And my first task was just to look at the literature and kind of understand, what had been done before. And before simultaneous PET MR, you can see that there were comparisons between PET and ASL in terms of blood flow, but this really depended on the days of separation between the PET and MR separate scans. So if you look at this correlation that was reported by the literature itself, you see this decrease in correlation between PET and MR as you go beyond the 1 week setting, for instance. And so if we want to take MR and validate it with PET, then the simultaneous PET MR not only is a convenient platform because you're doing a single scan, but when you're trying to validate physiological biomarkers, it may be really important to do this simultaneously because physiology, including blood flow, varies with time of day, with diet. If you've had a cup of coffee to stay awake during this presentation, your blood flow may have decreased by 30%, right? So this is a way to actually observe the same physiology by two modalities exactly simultaneously. And so let me talk about what one of our experiments looked like. So we injected O15 water as a reference. So this is radio labeled water for PET, and that is our gold standard for cerebral blood flow. And then we're comparing, in this case, a Moyamoya patient with bilateral disease, various ASL paradigms to that PET gold standard. So what you're seeing right now in front of us is a blood flow map from a standard ASL MR scan with a post-label delay of 2 seconds. And you look at this and there's quite a bit of heterogeneity, and it's hard to interpret until you see this reference standard from O15 water PET. And when you look at the two images side by side, certainly the cortical perfusion is more uniform on the PET, with some hypoperfusion in the anterior circulation as expected for these Moyamoya patients, but it's certainly more heterogeneous on the ASL. And looking at these across multiple cases, we can come up with some hypotheses where a lot of these heterogeneities we think are coming from arterial transit effects. So on the left hemisphere here, you see these hot spots, and these higher signals may reflect labeled blood that has arrived to the imaging slice. So we're capturing it in scan, but it hasn't perfused into the microvasculature of the tissue. So these signals are stuck in macro vessels, leading to these hotspots that we don't see on the PET. And on the other hemisphere, you see this lower signal where potentially the transit time is so long, even longer, that the signal that was labeled in the neck has not even arrived at the time of imaging to the brain slice, right? And so we can have auxiliary information to try to test these hypotheses, such as a contrast-based MR scan that gives us information about timing, and it exactly follows our prediction where there's bilateral increases in transit time, but especially on the right hemisphere. Another way to kind of look at this problem is to use a different ASL strategy where instead of one post-label delay, we acquire 5 different post-label delays sequentially, and this allows us to fit a kinetic curve to the ASL signal, which allows a measurement of arterial transit time, so the arrival time of the signal, and calculates a mitigation, a correction for our cerebral blood flow. And with this multi-delay strategy, there's certainly a trade-off in terms of spatial resolution to accommodate multiple post-label delays. But what you see is an ASL map. If you have 5 different post-label delays spaced as shown here, the cortex flow is much more uniform and more similar to the PET. And with the arterial transit time information, you see a pattern that's asymmetric, especially on the right hemisphere, just as we see in the contrast MR. And if we wait even longer, so a long delay ASL of 4 seconds, we see that the perfusion does get to the cortex, but by then, due to differences in relaxation and iron quantity in basal ganglia, you see that the perfusion in the basal ganglia has decayed away already. And so that's an artifact where it's very easy to miss the deep gray matter flow. So this slide summarizes an example of what an experiment looks like in one of our Moyamoya cases. Here's another quick example where this patient had a previous stroke, as seen on this FLAIR scan. And in this case, there's a true deficit, which is hard to tell on the standard ASL because we see flow voids on both hemispheres. And it's really only with the multi-delay ASL and especially the long delay that we're recovering this very long transit time flow and being able to distinguish between the 2 hemispheres in terms of a true deficit versus an artifactual signal void. So with these examples, we did some regional analysis, and this slide shows brain regions only with very severe transit time. So in this case, a Tmax from contrast MR greater than 5 seconds. And you can see that each of these ASL scans that we've talked about do correlate with the PET information, but that the correlation is strongest with long delay times in these cerebrovascular populations. And especially if we are able to take the Bland-Altman plot and look at the potential bias, you see that ASL with the single delay and the multi-delay tend to underestimate flow, and it's really extending the delay time that allows us to recover the blood flow that we observe on the reference PET scan. So with this observation and the fact that using multi-delay gives us information about transit timing, I think our conclusion from this is that for patients, it's really recommended to use multi-delay for correction, but if you're using a multi-delay ASL, it's very important to extend the post-label delays, for instance, up to 4 seconds in these cerebrovascular populations. And when we look across the cohort, I want to show some maps now. This is basically taking a voxel-based approach and looking at group comparisons between Moyamoya patients compared to controls. And so the question that this diagram is trying to ask is, what is the hypoperfusion that is identified with PET? So how many patients out of the 20 identified hypoperfusion? And what does the pattern look like when you compare ASL to ASL? So an ASL scan in a patient to an ASL scan in a healthy control. And you see that the standard ASL dramatically overestimates the region of hypoperfusion that we see in these patients. And what's also really interesting is if we then take the opposite and look at hyperperfusion, so we don't expect there to be necessarily hyperperfusion in these patients, actually we still see this interesting posterior signal, bright signal, and we think this is actually driven by collaterals, leptomeningeal collaterals that develop in the posterior circulation because Moyamoya patients tend to suffer flow deficits anteriorly. And so perhaps these are collaterals with slow flow with that intravascular macrovessel artifact that's showing up right here and being misled on ASL as hyperperfusion. So when you look across the cohort, these are really interesting trends that we're starting to see, and showing that, you know, with PET and ASL, you can really start to tune the ASL so that we can achieve the same diagnostic accuracy as PET. I want to also quickly go over a couple of extensions of this work, these sort of experiments. And one is not looking at flow just at baseline, but also thinking about reactivity. So if you think about the diagram here where there's potentially a restriction that causes regional resistance and blood flow, then perhaps the flow downstream here, so the microvessels have already augmented to the maximum capability in terms of supplying the downstream tissue with flow. And so in this case, autoregulation is very much impaired adjacent to the regional resistance. So if you're giving a stress test for the brain, so having the subjects breathe a hypercapnic gas or take an acetazolamide, which is a carbonic anhydrase inhibitor that also increases blood flow, then there's not only potentially impairment at baseline, but there's impairment in the ability of these vessels to respond to a stress test. And in this case, you know, we are also starting to see not only that with PET, we can quantify this augmentation, but also paradoxical decrease in flow called cerebrovascular steal. We're starting to see that with ASL as well. And you can imagine that this sort of paradigm where we're looking at multiple physiological conditions is even more reason to do PET MR simultaneously for validation, because especially, for instance, with acetazolamide, this diamox administration, there's not a good understanding of the reproducibility. So if I give you diamox in one setting versus the next, I mean, nominally it maximally dilates the vessels, but there's not clear evidence that doing it in one session versus the next session, that you'll get exactly the same augmentation. So if you're trying to validate this stress test, then it could be even more important to do PET and MR simultaneously. And you know, we also leverage this to develop a way actually to avoid some of the challenges with quantification with PET. So usually if you have a PET scan with O15 water, as shown here, to do this quantification, you actually need blood sampling to understand how much tracer was injected and then calculate the quantitative blood flow in baseline and then after acetazolamide or some sort of stress test. And what we did with the PET MR is actually avoid the blood sampling and instead say, well, we trust the regional distribution of the PET tracer, and how can we scale this to a blood flow map with knowledge of the mean blood flow across the whole brain? And this information we extracted from a simultaneous phase-contrast flow. So the 4 major inflow arteries to the brain, we obtained the total blood inflow normalized by the brain weight and use this to scale to the absolute CBF. And so with this PET MR paradigm shown here, we're getting a quantitative blood flow map that is not subject to some of the challenges of artifacts with delay, but we also have quantitative information from phase contrast. So this is a truly hybrid biomarker to avoid arterial blood sampling. And with this PET and MR synthesis, then we're able to show quantitative assessment in healthy controls that exhibit a augmentation in cerebrovascular reactivity and a subsequent impairment when we compare this to Moyamoya disease in terms of level stenosis and its impact on the reactivity. So in this sense, we have developed a non-invasive way, and we're also looking now into, in different conditions, how does ASL perform when we want to look at cerebrovascular reactivity. And here's an example of multi-delay and standard delay ASLs compared to PET. And the blue shows where ASL is underestimating, so exactly in this deep gray matter, due to short arterial transit times. So even at baseline, as we saw earlier, the deep gray matter has shorter arterial transit times, and so it tends to underestimate flow because the signal gets there and it decays faster away. And when you give a stress test, then what we're seeing both in healthy controls and in Moyamoya patients, not only is there faster flow, so the arterial transit time is shortened in the green across more of the brain, but that corresponds to an even greater underestimation of ASL compared to our synthesized PET metric. So it's another caveat. This is something we're still looking into, but not only are we concerned about long transit times, but if we're trying to look at different conditions, what we're trying to suggest here is that we should also pay attention to short arterial transit times, including in the deep gray matter, because these are very important considerations for quantification. And very quickly, I'm just going to give a shout out to my colleague, Jia Guo. He is a current faculty at the University of California, Riverside, and he's taken this same data set into a very different direction with machine learning. And the question is, if we can take multiple ASL data and structural data and actually train with these combined pairs of ASL and PET to directly use a convolutional neural network, as shown here, this UNet structure, and instead of going back and changing all the imaging acquisitions, can we use the existing inputs and actually train the network to correct for these artifacts? And it's really exciting work because as you can see here, some of these artifacts with ASL, which you can mitigate with multi-delay, actually are also mitigated by this neural network. So you see, compared to either of these ASL acquisitions, the error compared to PET from the neural network is much less, and it addresses some of these artifacts that are highlighted in the arrow here. And we're also thinking about how this performs in terms of training. So for instance, if you train the network relating ASL to the PET reference only on controls, then when you test on a patient, the network hasn't necessarily learned to correct for the artifacts that show up only in patients. So you see this great error here. And it's only when you train on patients themselves or train on the mixed cohort, the network learns to correct for some of these artifacts that show up on the ASL. So that was a lot of information, but I hope you can appreciate that the simultaneous PET MR allows us to take an ASL scan and consider multiple inputs and try to create a PET-like output that's more robust to these artifacts. And what's exciting about this is that even other centers who don't have a PET MR, ultimately, if we can develop this algorithm and share, then they're able to take their ASL scans and also apply the network to create a PET-like blood flow image, even without any PET scans or cyclotrons. But this, of course, will depend on sufficient training across different types of patients, especially as shown here too in terms of bias analysis across different cohorts. I'm going to just skip this. And as a quick summary, what we've talked about now is mostly the cerebrovascular story. We've talked about how to optimize ASL compared to a simultaneous PET. We've used hybrid measurements with PET and MR to get these cerebrovascular measurements. And then we've touched on the deep learning aspect that really leverages simultaneous PET MR to enhance our ASL measurements of perfusion. So now I'm going to move on to the second part of the talk, which is bridging my work from stroke into a new domain, related domain in neurodegeneration. And there's really been a shift in Alzheimer's disease, especially in recent years, toward diagnosing these diseases based on purely clinical assessments, which are challenging and can be subject to patients reporting their symptoms in different ways, to really understanding Alzheimer's and non-Alzheimer's pathological changes as biological constructs. And the power of imaging is now enhanced with new tracers that allow us to image in cognitively normal and AD patients deposits of amyloid and tau. And so what I want to share here is how these sort of disease-specific markers can be combined with our understanding of downstream neuronal injury, including cerebrovascular disease, to assess cognitive decline. So this is my overarching goal in the long run, but I want to just share some initial steps toward this biomarker cascade using PET MR. And one of the studies that has really leveraged PET MR that we did at Stanford is using a very basic tracer called FDG to look at glucose metabolism in patients with Alzheimer's disease. And here's an example showing the hippocampus and a associated segmentation on the T2 weighted MR. And this segmentation has been overlaid onto FDG. And what has been segmented in the hippocampus are these subfields as shown here. And what's really interesting and really helps with the PET is delineating these sub-regions. So if you can look at this PET that is overlaid in the color, it is very obvious that the spatial resolution, even with the best detectors that we have right now, is still relatively poor compared to MR. And when we do the subfield analysis, some really interesting findings come out where when you compare the control mild cognitive impairment and AD patients, if you look across the whole hippocampus and you look at the uptake SUVR of FDG, you don't see much of a trend. And it's only when you look at individual subfields, especially here the dentate gyrus, that you start seeing hypometabolism in very specific fields. So not only would this allow us to perhaps identify trends of hypometabolism earlier, but it also helps us understand how the disease progresses throughout even different sub areas of the hippocampus. And this is really improved by the exact image registration between PET and MR in these patients. And this also helps for a different study that we have led, which is with a new tau tracer called PI2620. So there have been previous tau tracers which have had issues when you compare with the neuropathology. And at Stanford, we were able to initiate some studies with a second generation tracer that has improved binding to these specific tau deposits. And with PI2620, we recently published a paper that shows the uptake in healthy controls and cognitively impaired patients. But one of the existing challenges, even with these second generation tau tracers, is still off-target binding. So on the top row, you see a normal control. And one of the places where we're starting to see uptake earlier of tau is in the medial temporal lobe, as you've seen here. And this is an area that shows tau elevation quite early in the disease process and continues to aggregate throughout the disease progression. But if you look here, there's actually additional off-target binding in the cavernous sinus that could be very confusing to a radiologist or neurologist interpreting these scans. So one of the ways in which MR, again, with high structural resolution can help us is to really disentangle some of these off-target bindings to true uptake that we see in the medial temporal lobe. And beyond just structural localization, we've also used this new tau tracer, and we're using non-invasive quantification. So in these patients, we're using image-derived input functions, again, to avoid blood sampling. This is done on our 3 Tesla GE PET MR. That's the same one that I showed for cerebrovascular studies. And we're showing these dynamic studies in 12 cases in the next few slides. What we did here is actually take an image-derived input function that really leverages the high sensitivity of our PET detector. So the GE PET MR system has time of flight information. It's one of the best detectors among all PET scanners, not just PET MR. And what that allows us to do is to take very short time frames. And so in this case, for just the 10 seconds above or right after the injection, you see this PET angiogram. And if you correspond that to the MR angiogram, which has higher spatial resolution, then we're able to mask out the arteries to extract input function information and really correct for the spillover due to poor resolution in this PET. Because we know the true volume of these arteries from the MR information. And this is the type of image-derived input function that we're able to extract from PET and MR information. And so with appropriate corrections, we compared this dynamic quantification to a static SUVR for this novel tau tracer. And some of the quantification we did in terms of dynamic analysis include graphical models, as well as 1 tissue and 2 tissue compartment kinetic modeling of our dynamic PET scans. Here are some examples of what we see. So in mild cognitive impairment, again, we're really starting to see uptake in the medial temporal lobe, although everywhere else, including like the lateral temporal and lateral parietal lobe, it's quite heterogeneous across our subjects. So at early stages, again, it's really the medial temporal lobe that's showing tau uptake. And you can get quantitative information from the kinetic models of the volume of distribution in the tracers. Here's an example in an AD patient with the tau tracer, and you can see dramatic uptake that is spread throughout the brain. And in atypical AD cases where they have visual impairments, you see this posterior uptake in the occipital lobe. That's really interesting for this tau tracer as well. And with the image-derived input function, what we were able to do is start correlating SUVR, which again is the static time frame for PET, with our distribution volumes quantitatively from the Logan plot, so graphical method, as well as other dynamic kinetic models of the PET. And so remember that these x-axes are derived from input functions that use both PET and MR information. They're more quantitative because SUVR can be determined by many other things like the patient body weight, flow, many other physiological processes. And as we're correlating this in this ongoing study, we really are using this as a way to test and choose between different quantitative biomarkers that could improve on SUVR, but also potentially for clinical settings, helping to decide on the appropriate time frame for a static SUVR, because with such a new tracer, it may not be settled yet exactly what the appropriate time frame should be for a clinical PET scan. And as I said, this is still ongoing. We're seeing even beyond the 90 minutes that in some regions this SUVR is still increasing. So to be determined exactly the optimal time frame for this new tau tracer. And again, we have off-target binding the cavernous sinus as well as some of the sagittal sinus as well. So with these caveats, I think the PET MR is still allowing us to leverage quantitatively the tau PET information beyond what we can get with just a PET CT. And we're really using this now to explore more between MCI, AD, and healthy controls. And the last thing on neurodegeneration I would like to touch on is, well, going back to this cascade that I'm very interested in, how can we think about these biomarkers in a way to overlap what I talked about in the first part of the talk with blood flow and dementia. And one of the ways that we can do this is actually perhaps getting multiple information from a single PET scan, or actually not even a PET scan. What I mean by that is, here's a study that recently came out from Belgium, published in EJ and MRI, where multi-delay ASL was compared to FDG PET. And what we see often in AD patients, and is a known pattern, is if you look at this PET on the bottom, you see a hypoperfusion or hypometabolism, in the frontal areas compared to healthy controls. And what this study showed is that you're able to recapitulate some of that with ASL. You see this decrease in signal. Interesting, this study also pointed in these arrows to lack of ASL flow in the basal ganglia, which we've talked about quite a bit already. So it's consistently observed across multiple studies and multiple centers. And in this same study, they did an SPM analysis, so comparing where there was hypometabolism in AD patients compared to controls, and you're starting to see some similarities between FDG and ASL. So that's really exciting because it means maybe the metabolic information that we use to look for a specific spatial pattern in AD patients, maybe instead of FDG, we can do ASL and avoid radiation. And if we have a PET MR, then perhaps we can be acquiring ASL on the MR, where the PET is then, let's say, opened up for acquisition with an amyloid or a tau tracer. And in a similar vein, we can also think about if you take the early uptake, so let's say the first 5 minutes compared to the late time frame of a tracer like amyloid. I mean, amyloid is, as a structural deposit, here this patient is a positive case because there's bleeding between the gray and white matter. This looks nothing like the ASL, but actually if you take the early time points of a dynamic PET scan, even for amyloid, which is not designed to be a flow tracer, you see a pattern that is very flow-like. And you can actually correlate with PET MR the early amyloid uptake with ASL. And so with one PET scan, you might be able to look at different time frames if the patient is able to be in the scanner early and late, and actually get both flow and amyloid information from one injection. And this information could also help us develop improved kinetic modeling. So here's a study I really like from the University College London, where the kinetic modeling usually requires the subject to be in there for a really long time for amyloid. But what if we could focus on the later time points and actually with a PET MR acquire ASL? So this ASL information would recapitulate the initial flow delivery and allow us to avoid actually scanning the PET this entire time, but still recover this sort of tracer uptake curve and be able to create more quantitative measurements with a proposed method using PET and MR but only with a shortened time frame. So lots of information again, but the key points here is that MR offers not just structural information, it helps us get quantitative dynamic analysis to improve our PET assessment. And if you have a PET MR, then the flow information from ASL can be used as a biomarker of its own, like similar to glucose metabolism in pattern, or it could be used to improve the modeling as shown here. So I've talked a lot. I just want to quickly summarize. We did initial studies in AD patients in MCI with a new tracer called PI2620. We really showed quantitative improvements and have thought about how to leverage multi-modal PET MR scans to improve quantification of both flow and amyloid. So with that, I'm going to just thank all our funding sources and the many, many people that have supported me, advised me, collaborated with me at Stanford and now at Davis as well. And I'm going to end there and happy to take your questions. I want to leave it on this final slide. Thank you so much for listening to this talk.
Thank you so much, Audrey. So what we really miss in webinars is the applause, because now you should have this sort of standing ovation. That was fantastic. Thank you so much. It's really great to see how you're really integrating these two modalities and just not just, you know, combining them just as is, but really just getting so much out of it. So the first comment we got already was from Esther saying, great to have you here, Audrey. So the people that have questions, so you can type in the window, but you could also, apparently there's a raise hand function. And if you do that, I can unmute you. So of course, I need to keep an eye on whether people can are actually raising their hands and are typing. So maybe a first question from me. So what I really liked was the idea, so that was your colleague's work, using the machine learning to then sort of correct your ASL images with the PET data and sort of looking at maybe a range of diseases. So do you think we need to sort of sample or train this on any disease, or would it be okay to sort of have the range, you know, the ones with the very long ATTs and the short ATTs, and have that range? What's your thoughts on that?
Yeah, no, that's exactly the questions that we got from reviewers. So for instance, the initial study that I cited from my colleague Ja, we did the training in healthy controls and in Moyamoya patients. And as we've talked about, those patients have very long transit times. So we do think the Moyamoya cases are a good representation of like cerebrovascular disease with delays. The question we got from reviewers is exactly that. Like, so what about dementia? Can you show that this network can be applied to AD patients? And you know, in responding to that, we did, you know, try to rationalize that, well, AD patients also have transit delays, which are probably the biggest contributor to artifacts in ASL, but they're probably not as long as the cerebrovascular disease. So there's somewhere in between where we think it's going to perform adequately in those cases. But of course, we should demonstrate that. And actually, Greg Saharchuk, who funded these initial studies, he then got a supplement from the NIH that is just funded recently to extend this research to dementia cases. So we're going to do the O15 water and ASL for dementia cases as well.
Oh wow, that's
question.
Yeah, I guess that's a very different group of patients, because they of course have, you know, other things as well. I mean, they generally have a global hyperperfusion, for instance, and yeah. Let's see. Esther has typed a lot. So she writes. She says, sorry, no mic. So I'm going to have to read out what she says. I like the example of the hippocampus where you use the segmentations based on structural MRI. Can you comment on what this means for the PET? i.e. there must be some blurring there. Do you use partial volume correction or something like that in the PET data then as well?
Yeah, I think there are numerous studies to do partial volume correction. I don't think we did anything fancy. I think here we really just used the basic interpolation from the scanners and from our image software. But if you look in the literature, there's certainly ways to actually adapt the reconstruction with resolution of MR and reconstruct together a synthesized PET map with better resolution, but we didn't do that here. But I think that's really promising because even without a reconstruction-oriented partial volume correction, we were seeing these different trends in subfields versus whole hippocampus. So it's a great question.
Yeah, and again, I guess that's where you can almost inform your PET on sort of structure as well, once you've sort of, you know, got that built in almost. Yeah. Any other questions? We've still got everybody on the line, which is very unusual. Usually on a webinar, you sort of see people leaving, but I don't see any more questions. So I guess we're going to have to conclude at 1 minute to 6 anyway. It's been amazing to listen to your talk. I know there's also a hope that we can collaborate somehow, or at least Esther's group and Fatime, who's of course been in touch with you to organize all of this. And I hope we can, and using all of these online tools. Again, to everybody else on the line, so if you're ESMRMB member and if you think that you're able to sort of host a talk like this, please let ESMRMB or myself just know, and we can schedule you in to have something very similar to this. Thank you so much, Audrey. Again, Esther, comments, really nice overview. Thanks a million. And thanks again. And have a nice...
Email me if any questions do come up. So
great. Thank you. Thank you so much, Audrey, and thank you all for listening. And see you all at some conference or online meeting soon. Bye-bye.